Today, we present to you a very rare but lethal complication of myocardial infarctions, which are left ventricular pseudoaneurysms. These pseudoaneurysms are characterized by left ventricular wall rupture and is contained by pericardium or scar tissue. Our patient is a 60-year-old African-American male with extensive cardiovascular history of coronary artery disease, status post-coronary artery bypass graft 11 years ago, hypertension, 40-pack year smoking with chronic obstructive pulmonary disease, and current IV drug user. He presented to our emergency department with substernal chest pain. Electrocardiogram on admission showed ST depression in leads V5 and V6 with a troponin peak at 8.36 nanograms per milliliter. Given his recent diagnosis of a posterior dural abscess at T3 and T5 with methicillin-sensitive Staphylococcus aureus bacteremia, a cardiac catheterization was not performed, and conservative medical therapy with low-dose heparin drip and clopidogrel was pursued. Initial echocardiogram showed an LV ejection fraction of 45 to 50% with no gross abnormalities, and even with medical management, patient continued to complain of chest pain throughout his hospital admission. A nuclear study showed ischemia in the left circumflex artery distribution, and 10 days since the day of admission, a transthoracic echocardiogram with contrast showed reduced left ventricular ejection fraction of 45% with a contained free wall rupture of the basolateral wall. Chest CT at this time with contrast showed a coronary grafts extending outward towards a large low attenuation mass in the left lateral aspect of the left ventricle, and within this mass was a second mass of mildly increased attenuation measuring 4.2 by 3.6 centimeters. Cardiothoracic surgery was consulted, and given that the patient was hemodynamically stable with resolving chest pain, they recommended continuing with medical management. Left ventricular pseudoaneurysms are a very rare complication of acute myocardial infarction and occurs when cardiac rupture is contained by adherent pericardium or scar tissue. We present a case of a lateral wall pseudoaneurysm with contained rupture by the pericardial adhesions caused by the previous coronary artery bypass graft 11 years ago. These pseudoaneurysms unfortunately tend to rupture with catastrophic complications, and traditionally, the preferred management of these pseudoaneurysms have been emergency surgical intervention with the mortality rate ranging from about 10 to 36%. In cases where surgery cannot be considered, like in ours, because of high-risk features, medical management is preferred, and mortality rate pushes to about 48 to 50%. Given our patient's hemodynamic stability, we continued medical management, and to the best of our knowledge, this is the first described case of hemorrhage contained by pericardial adhesions caused by the previous CABG 11 years ago, making this case very unique. The aim of this case is to raise awareness regarding the diagnosis of left ventricular pseudoaneurysms among patients with high-risk features, such as previous myocardial infarction, chest pain, and an age greater than 55 years. Most patients with left ventricular pseudoaneurysms present with nonspecific symptoms, such as shortness of breath and fatigue, and therefore a high index of suspicion is needed to make this diagnosis.